You know we're getting old when your friends and colleagues ask you to speak about the future. They never ask a young guy to talk about the future. They haven't lived enough. They don't know the past to know the future. Aortic valve surgery continues to evolve. It started to evolve when I was a brand new resident, like most came up today and spoke, and continues to evolve. Because I'm in England, it might be appropriate to tell you about change. The concept of change came from this country. It's inevitable. It's going to continue to change, and if you want to be an ostrich and bury your head, be so, but become part of the past only. You know, we have been very creative, innovative human beings, but it's interesting. At the same time we do something in our arena, in our domain, somebody else comes and put a pin in our balloon. We developed, in this country again, aortic valvotomy for congenital aortic stenosis. Lord Brock did the first one. Soon enough, a Japanese came up with a balloon to do percutaneous balloon valvotomy and abolish entirely open valvotomy congenital aortic stenosis, or just about entirely. We developed aortic valve replacement. Various ways to do it, thoracotomy, sternotomy, name it. We don't know which way is best yet, but now we have percutaneous delivery. I heard one of the speakers saying in his center, they are favoring now aortic valve implantation opened. They remove the valve and deploy a valve percutaneously with no data about the future. But that's the preferential treatment that you in Italy. They have this gut feeling that implanting a valve is better than 60 years experience with securing stitches. Why are you like that? Are you just curious? Or are you really trying to raise the bar to a higher level? Thank God for people like that. Otherwise, there will be no future. But I hope that those who do are like I am, critic enough to keep looking at what you do upside down all the time. I don't know if you guys are aware of this. I have done more than heart surgery in my young years. I was a computer guru in 1978. I invented database. I put the first database in cardiac surgery ever published. Very simple program. Used to be called the basic language. 0 and 1, 0, 1, but I was able to do a database. And my database, my own creation database, allowed me to keep looking back what I was inventing to see if it was right or wrong. We don't know if this is right or wrong. But believe me, it is here to stay, and soon there will be percutaneous or lesser approach to repair the aortic valve and to replace aortic root aneurysm. One of my younger associates has a prototype to do a bento percutaneously with 2 coronary artery stents. So he's assuming that the stent in coronary artery is a good thing. And all the trials show that it's a palliation. But yet we're going to be moving the envelope. This was likely a evolutionary but revolutionary once was done, the TAVI. And to be quite honest, in 2007, when I started doing my unit, I was certain it was not going to work. But another Canadian, John Webb, had done 107 when I met him to learn how to do it. And he looked back at 107, 90 patients went home. Of those 90 patients that went home, I don't think I would have done the operation 10 of them because I was afraid to. The risk was too high. And indeed, the very high risk aortic valve replacement has no different outcome than TAVI. And they are so old that it doesn't matter very much. I guess somebody mentioned before, mismatch is not important at 80-year-old or 90. If you can get them out of heart failure or can get them out of the hospital, that's an accomplishment. It's expensive, but if you can afford, why not? It is like the guy who opens the aorta, make an incision, remove the valve, and deploy percutaneously instead to stitch the way the dinosaurs like me do but Germans might be ahead of us. Michael Borger was in Toronto in January, and he doesn't have the data yet, but he said that 30% in 2011 jumped to 33%. Half of them, people under 70. And patients want that. They don't want to be cut. We live in an era of very fast information. My daughters gave me an iPhone for Christmas with 64 gigabytes. That's more powerful than the computer that had my database in 1978. My IBM that I bought in 78 to write my basic program had less than 1 gigabyte. This damn thing has 64, and I carry in my pocket. And it's 64 times more powerful than my computer of 30 years ago, 35 years ago. We're accustomed to fast, quick answer. People want a fixed solution. That's why the same Italian told you the patients prefer this one here. I have a resident who tried to convince me that thoracotomy was better than sternotomy by taking me to his hospital and show a patient 7 days later doing push-ups with thoracotomy. There's no way our patients can do push-ups with upper sternotomy or a full sternotomy. You split his sternum into halves. This is evolution. This is evolving. We are trying to keep changing. And I'm afraid, my friends, whether we like or not, this is here to stay, and there's going to be a deja vu with coronary artery stents. It's going to be very difficult to prove that is better. If you prove that is better open than TAVI, if the patient says, can I go home tomorrow with TAVI? Yeah. Doesn't matter if you offer thoracotomy or sternotomy or big, small incision, they're going to pick the groin incision, the puncture in the groin. Even if it lasts 25 years, because I want a solution for my problem now. I don't want to invest too much time on my problem. Our culture is changing. And then you heard ad nauseum in this meeting, should you use a prosthetic? I mean mechanical valve, prosthetic valve. 60 years of heart surgery. 58 years of aortic valve replacement. And we don't know yet the answer. It looks like after 60 years, the conventional wisdom has that the type of valve doesn't matter as far as survival is concerned. So whatever you put in your heart, they're going to live the same number of years that one or other valve you give them. Those who chose to have mechanical, they are bitching. They don't like the blood thinners, they don't like the noise, they don't like the nosebleeds and the potential bleeding that warfarin causes. And those as tissue valve, and if they are young and smart enough, they are worrying sick that one day somebody's going to open them or put a TAVI on them or whatever to solve their problem for a longer time. Look at mechanical valves. This valve here is 58-year-old, the Starr-Edwards valve. There is no difference in outcome proven that this valve here is better than that. None. Survival, thromboembolism, thrombosis, name it. As a matter of fact, there is a lot of scientific evidence that this is the best aortic valve if you orient towards the non-coronary sinus. Most laminar flow, the least thromboembolic complication, the least reoperation for Panus ever in experienced hands. And yet, we became a bileaflet world. If you use a valve like this or that in your patient, your cardiologist say, are you out of your mind? Yeah, but it's better. A single disc valve is better for the flow. It's better for the heart. It's better 30 years later. And yet we abandon what is best for what is popular with no scientific basis. If there is a scientific basis, should have stopped here. Should have stopped with the original Bjork-Shiley or even better one, the Monostrat. There is no valve can compare to Monostrat Bjork-Shiley in durability, thromboembolism, and Panus. Those valves do not fail 30 years later. This one developed Penus. This one here, 20 years. 2/3 of patients have high gradient, have mismatch. Because the pattern of flow is such that it stimulates Penus formation. I don't know why we changed, but we changed. And it's almost irreversible. Because companies are not willing to spend $10 million again and develop a new single disc for aortic position. I'm not talking about mitral, aortic talk today. How about the stent versus stentless? When I came up with the concept of stentless, I said, now the aortic valve replacement problem is going to be solved. Very short sight. We stopped using it because after 20 years of experience, I could not show difference in outcome. Actually, hemodynamically, I think it was spectacular. And that's why the survival of Toronto valve parallels the survival of the population of Ontario in patients prospectively followed. These are clinical trials. Observational, not randomized, but prospectively follow patient. So you didn't miss any patient. But somewhere at 12 years, the curves start crossing and they start going down. We're going to publish now 20 years of outcome. And survivorship is no longer the same because too many of them came for reoperation. And we killed 10% of reoperation. So the gap became 10% difference. Stentless valve are no more durable than a stented valve. Doesn't matter which stent it is, Freestyle, Toronto, doesn't matter which one. They're all inferior, if anything, in durability. So when I compare Toronto with our experience in Hancock 2 valve, a very old valve, but unmatched for durability. No hemodynamics, nothing else. Just durability is unmatched by any bioprosthetic valve ever used in humans. The difference is too large. Same age population, matched for age, matched for body surface area, and yet I had a 20% difference in freedom from reoperation. I couldn't justify to continue using Toronto valve, so I went back to a 30-year-old valve. Just like Starr Edwards, Bjork Shiley, and St. Jude, the evolution was a mechanical valve. We start doing porcine and pericardial simultaneously. The design of the pericardial are so bad, are so appalling, that porcine won in the 80s and early 90s. But there comes a guy called Ernie Lang, a smart engineer, that he learned that pericardial fails because it bends too much. Anything fails if it keeps bending. So design a valve that doesn't bend too much. Design a valve called perimount. Perimount is very restrictive. The leaflets move between only 28 to 35 degrees. So the stress in the pericardium is dramatically minimized. Guess what? Became very durable. So a bad valve, bad tissue, you change the design, becomes more durable. And there comes Ramintula, a man who I respect immensely. 3 times already in his cardiovascular update, he says, pericardial valves are more durable than porcine valve. And everybody says, amen. What is the evidence? Oh, the evidence is from 1980, 1970. Well, that's nonsense. The porcine valve in 1980, 1970, in those days, we did not know that age was the single most important determinant in outcome of bioprosthesis. So if you compare data from the 80s, of course, pericardium is better than porcine. If you compare current data, there is absolutely no evidence that pericardium is better than porcine. Actually, when we prepared this manuscript, we had 1,000 patients, not very old, 67 mean age, but a pretty wide spread up to 92. 20 years later, 2/3 of patients had an echocardiographically normally functioning valve. This is by echo. But then you break down by age. The people over 70, it's a wonderful valve, up to 20 years. Small sample size, because people who's 70, you replace a valve today, their chance to be alive at 90 is not very high. But my vintage here, it's a pretty damn good valve too. I don't think twice about if I need an aortic valve replacement, what I want in my heart. 90% freedom from echocardiographic evidence of valve failure. Remains a major problem in people under 60. The average age of this group was 47. So in a 47-year-old, we don't have a good solution yet. We reviewed the literature extensively in any paper ever published 15 years or more. Less than 15 years, there's no point in comparing durability of bioprosthetic valve. And we could not find anywhere in the literature that porcine is worse than pericardial. On the contrary, if you try to do a matching between multiple institutions, which is not very valid statistical methodology, pericardial is inferior to porcine. But yet, we changed. It has become a pericardial world. You guys are embarrassed to put a porcine valve anymore. Not me. I continue using it if the end is big enough. Pericardial is better hemodynamically, and since I worry about patient prosthesis mismatch, I try to use the best hemodynamically available valve for the given patient. But there is no proven that pericardial is more durable than porcine. On the contrary, it's less durable. Just like the Bjork-Shiley and the St. Jude valve. When I say Bjork-Shiley, I'm saying single disc versus double disc. Single disc mechanic is better hemodynamically and in durability than double disc. And yet, we all changed to bileaflet. And God knows why. Why the future came this way without scientific basis is puzzling. Puzzling to me, at least, as a student. The key of tissue valve is try to two things. Find out why the leaflet become stiffened, like in pericardium, or tear, like in porcine. And there's a multitude of the nature of the tissues one is very important. Clearly, pericardial fixed glutaraldehyde is stronger than a porcine aortic valve. So tissue by tissue, pericardial wins. But pericardial wasn't meant to be a moving structure. So stiffness is a major problem in calcification. Arnie Lang in California showed that the cusp design is the key if you're going to create a valve for durability. And of course, since he discovered this in 1981, everybody else jumped in the same bandwagon. What I'm trying to convey to you about the future is be aware, very aware, of valves that open too much if they are made of pericardium. I want to see the 12, 15 years durability. There are 2 or 3 in the market now, incredibly perfect hemodynamically, because the pericardium opens all the way to the size of the orifice. One of them, bigger, is a reverse funnel. Is it going to be as durable as perimount? If I can predict the future, the answer is no. I have no financial interest in any company. Trifecta and mitral flow are doomed to fail prematurely because they both open excessively. They are breaking down the rule that was established 30 years ago by a very smart biomedical engineer, Arnie Lang. You have to know the past to predict the future. Tissue fatigue is the main reason why these valves fail. And unfortunately, none of them can repair themselves. What you heard in the past few days, 2 or 3 times I heard Dr. Verrier mention, my concern about this percutaneous valve is that you crunch the damn thing into a small piece and then open again. Do you expect the valve to heal itself? A piece of leather? Do this to your shoe. Put your shoe to a pressure machine and try to put your feet inside. Be very comfortable. But we do this to our valves in our hearts nonetheless. Dr. Wise and myself have a lab in trying to creating a living valve for 30 years, and we have failed badly. Never goes beyond the laboratory. We can't. Different kind of scaffold. We thought the polyglycolic acid, when it came in the 90s, was a solution. You could populate your own cells and put some of your stem cells there and try to develop a valve that could replace yours and able to heal itself. It was very complex. You need a matrix, you need a tissue, you construct the valve, and then either through culture of tissue or a bioreactor, you develop a valve that can be used for replacement. A very smart engineer from Purdue University proposed to bypass all this. If you have the appropriate matrix and use the matrix to create the device you want, a tube, arterial wall, piece of the heart, and then let nature, let your own stem cells to go there and make what you want, might work well. The initial experimental result, remember, experimental, I'm talking about the future now, on core matrix to replace parts of the artery, parts of the heart, are nothing short of remarkable. You're going to start seeing now a flow of papers in animals that is nothing short of spectacular. A small piece of aorta, if you take, say, a centimeter of aorta, put core matrix, within 1 year, all 3 layers are there. The core matrix disappear, you have adventitia, you have a vasa vasorum, you have elastic, you have an intima, endothelial cells. But as the piece becomes bigger, like centimeter in 6 months, 2 centimeter, 1 year, 3 centimeter, it began to fail. The cells do not populate the matrix fast enough. I was part of this experiment. You take the tracas valve entirely out of the patient, take a tube, make a cylinder, invert the cylinder into itself, and secure in 3 places. So you create a valve. Suture the base into the tricuspid annulus and papillary muscle. That's how you look in sheep 20 weeks later. That's pretty scary. Those of you that work with animals, these look remarkably similar to the normal sheep tracas valve. More importantly, the autopsy showed that, look at that. A fenestration and resorption of the material began, and chorda tendina are appearing. At 1 year, we're going to be published now, normal tracas valve. 3 leaflets, chorda tendina, just like your own valve. Of course, in sheep, we don't know if the humans are going to answer it. But we jumped the bandwagon because our enthusiasm is no different than anybody else. We have 4 humans now with this tracas valve. IV drug users, one unfortunately went back and finished himself. But the other 3 were rehabilitated, and the longest follow-up is 1 year. By MRI, no technician, no MRI technician or radiologist can tell that is artificial tracas valve. The same for the pulmonary. The stem cells populate them fast enough to replace all the parts. This, I think, is the future of bioprosthetic aortic valve replacement. May not be core matrix, but it can be another membrane where the function makes the anatomy. In other words, if you assume that my hand is the way it is because adaptation over millions of years, or at least 25,000 we know, to become this way, likely the tissues of the heart are the same way. Their shape represents the ideal shape to fulfill the function. I don't think we should throw away biological valves. I think aortic homography is wonderful. It's going to remain wonderful in certain cases, particularly endocarditis. There's no replacement to scissors and knife to remove pus. If you're going to suture a tissue in pus, everything is going to fall apart. But if you're in doubt, if there is inflammation with residual bugs, it's a great material, very user-friendly, and solve a lot of problems in the operating room. I think we are learning more and more about the ROS, and next month we'll be talking about our 20 years experience, mean follow-up of 14 years. We have a cohort of 228 that they are captive. They keep coming back every year to our clinic. And so we haven't lost any patient yet to follow up. And the survival is identical to population in general. And we have to be careful when you look at population survival after valve replacement or biological materials. Because those patients that failed by Kaplan-Meier, they're eliminated. So we use a new formula, use intention to treat methodology by parametric analysis. And there is no difference, even using intention to treat, that these 228 patients with the average age of 32 live less than the Ontarios matched for sex and age. Aortic valve replacement with pulmonary autograft in our hands restore lifespan to normal. We had no failure in women. 98 female in this cohort of 228. Not a single one of them failed their biological valve. The bioprosthetic failed, the pulmonary homograft, and we had to put a percutaneous valve on them. But 100% 98 have a normally functional autograft that mean follow-up of 14 years. The longest one, 25. 95% of the aortic stenosis, men and women, have a normally functioning autograft at 20 years. The 5% that fail, when you read the up note, is a learning curve. The surgeon had trouble with a block of calcium. The autograft did not sit very well. And all failures that we had occurred in patients who had the aortic insufficiency as the predominant lesion or an aortic annulus larger than 27 millimeter. I cannot say much more because the paper is going to be presented at the AHS, but this is an abstract. How about repair? These operations are here to stay. These are no longer experimental. The key is to choose the patient carefully. You heard Dr. El-Khoury's team presenting the data today. He's trying to push the envelope, and I commend him for doing that. I'm too old, too conservative. I operate only normal valves. I spare normal valves. If you do that, if you're very conservative, don't take valves that are calcified, fibrotic, retracted. That is what I think you should expect. Mean age 47. Coincidentally, the same mean age of my cohort in Hancock 2 valves. Mean follow-up is relatively short yet, but up to 23 years. Survival up to 18, 20 years is identical population in general. Then the number of cases become too small to be significant. And that's not bad. That's better than any ROS procedure, any bioprosthetic valve, and likely better than a mechanical valve. Because you don't have a 94% freedom with St. Jude at 20 years. A third of them are very stenotic at 15 because of panels. And then, of course, reimplantation appears to be better than remodeling as far as valve function is concerned. But remember, this is a pioneer series. I did not know back here what anodilation meant. Nobody taught us that. We learned along the way. Annular aortic ectasia was a term described by Cooley, by Dr. Denton Cooley. When he opened the heart, he saw a big annulus. He said, well, this is annular aortic ectasia. We did not know the implication of dilatation of the annulus. Anodilation is a marker for a very severe connective tissue disorder in that patient. Bicuspid aortic valve is where the money is because 1% of us are afflicted with this congenital anomaly, and a third of us develop aortic insufficiency. So if you can find a way to fix those, and El-Khoury is trying very hard. He and Schaefer's in Homburg in Germany, most of their aortic valve repairs are in bicuspid. And I commend them for trying, if they are willing to take failures. But she published recently, if you do in bicuspid aortic valve, a reimplantation, short-term follow-up, but no failures. Why? Because he discovered that the annulus is dilated in bicuspid aortic valve that becomes incompetent. Actually, in bicuspid aortic valve, the annulus dilatation precedes the aortic insufficiency. Although I started by criticizing people that keep advancing the envelope, we need more Elcuris. We need more, like the Italian friend, doing an operation through a small thoracotomy and deploying valves there without suture, without stitches, to see what happens. I'd like to finish by a quote that I like very much and summarize my life. Nothing in the world can take the place of persistence. Talent will not. Nothing is more common than unsuccessful people with talent. Genius will not. Unrewarded genius is almost a proverb. Education will not. And I don't have to tell you the reason why. Persistent and determination alone are omnipotent. The slogan, press on, has solved and always will solve the problems of the human race. Thank you.